Welcome to This Medical Life podcast. These are the stories of medicine with Steve Davis and Dr. Travis Brown. This is the story of sleep apnea. What are you going to diagnose there, Dr. Travis Brown?
I would probably say that's normal, but that's probably not a normal thing these days after doing this episode, is it? So we are talking about sleep apnea, and unfortunately it's very prevalent, as we're finding out. This is something that the seed of this episode came from me experiencing some of these symptoms, snoring, and then my wife was saying that, oh no, every once in a while you're having these episodes where you stop breathing. And so I had to, I will see my cardiologist because I've got the FH. And then he said, oh, are you having symptoms of sleep apnea? And then, yeah, sure enough, it was one of those wonderful things. And I ended up going to a dentist, and the dentist, Dr. Mark Earle from Preventative Dentistry, said, there's, a whole range of options that are out. And so I sort of started going, I need to know far more about sleep apnea. And so this is
thank goodness you have a podcast.
That's right. And this was, when you actually dig into the history of sleep apnea, it's actually fascinating. It's the name actually is almost historical in itself. Now, that's not the name of sleep apnea. It's actually it goes all the way back to Charles Dickens. And his first ever published novel was called The Posthumous Papers of the Pickwick Club, also known as the Pickwick Papers. Now, this is not a single story. This is a series of different characters who were, loosely related, but they had adventures of the Pickwick members that would go around England and, report on their observations. But there was a minor character in this. His name was Joe the Fat Boy. And he was he was young. He was 15 to 17 years. He was overweight, always hungry, and always sleepy. He could fall asleep anywhere at any time. There was, he would fall asleep during tasks, even during meals as he was eating. Standing one time at the front door, he slept he slept at the, after ringing the doorbell. And Joe was also breathless, snored loudly, and red in the face. And there's a number of quotes from the Pickwick Papers about this.
The object that presented itself to the eyes of the astonished clerk was a boy, a wonderfully fat boy, habited as a serving lad, standing upright on the mat, with his eyes closed as if in sleep.
This is where, 50 years later, we find that doctors started writing about patients with similar symptoms. We actually had Dr. Richard Caton in 1889. He wrote,
at the beginning of 1881, his weight was 11 stone 4 pounds, or 71 kilograms. During that year, he gained 4 stone in weight, about 25 kilograms, and coincidentally, a tendency to drowsiness showed itself and progressively increased month after month, causing him great inconvenience. He had been fond of attending the theatre, but now he slept soundly through the most exciting drama. During the year 1882, he further gained 3 stone in weight. The tendency to sleep became constant and overpowering. It had been his habit to entertain guests frequently, but now he fell soundly asleep while carving the joint at his own table. Reading and writing became quite impossible. The moment he sat down in a chair, sleep came on, and even when standing or walking, he would sink into sleep. Constantly, while serving customers in his shop, sleep would come on as he stood by the counter. He would waken and find himself holding his hand a duck or a chicken, which he had been selling to a customer a quarter of an hour before, the customer having meantime departed.
Now, Dr. Caton was actually very interested in this condition, and he investigated.
When in sound sleep, a very peculiar state of the glottis is observed, a spasmodic closure entirely suspending respiration. The thorax and abdomen seem to heave from fruitless contractions of inspiratory and expiratory muscles. Their efforts increase in volume for about a minute or a minute and a half, the skin meantime becoming more and more cyanosed, until at last, when the condition to the onlooker is most alarming, the glottic obstruction yields. A series of long inspirations and expirations follow, and the cyanosis disappears. This acute dyspneic attack does not awaken the patient. If in the midst of the dyspneic attack he be forcibly aroused, the glottic spasm at once relaxes. The night nurses states that these attacks go on all through the night. Patient is himself unaware of them, excepting from what others tell him. His wife states that they have occurred with varying frequency for some years.
So at the same time, we had another doctor, Dr. Morrison, describing a poker player who suffered from sleep apnea.
SG, aged 43 years, a diamond merchant, tall, stout, married and a father of a healthy family, suffered for at least 15 years from drowsiness, and during the last 2 years became deeply somnolent. He would fall asleep while interested in and playing a game of cards, the card suddenly dropping out of his hands onto the table, and he beginning to snore, and his face becoming darkly engorged until his companions succeeded in rousing him.
Even one instance, the patient, like in Charles Dickens' novel, fell asleep on the doorstep while waiting for the door to be opened. Now, Dr. Morrison linked this to his poor sleep.
I have myself observed him asleep in bed with an intensely cyanotic countenance, a condition which he was aroused after a snorting and choking sound issued from his respiratory passages, the cyanosis then gradually disappearing.
He treated actually some patients with this, and what he treated them with was it was 5 weeks of vigorous massage, and they also lost weight. And so
I wouldn't mind that as a treatment. Why doesn't my doctor recommend that?
And so there was a dramatic improvement in the patient's sleepiness. And so the most known description, like the classical description, is actually from an article from Burwell in 1956. And again, there seems to be a theme. This is of an overweight poker player businessman.
He was a 51-year-old business executive who entered the hospital because of obesity, fatigue and somnolence. The patient reported that he had been overweight all his remembered life and for many years had weighed approximately 100 kilograms. When this weight was maintained, he was alert, vigorous and able to work long hours. As the patient gained weight, his symptoms appeared and became worse. He'd often fallen asleep while carrying on his daily routine. Finally, an experience which indicated the severity of his disability led him to seek hospital care. The patient was accustomed to playing poker once a week, and on this crucial occasion he was dealt a hand of 3 aces and 2 kings. Because he had dropped off to sleep, he failed to take advantage of this opportunity. A few days later, he entered the Peter Bent Brigham Hospital.
This came to be known as the Pickwickian syndrome. And again, they were linking most of it to this weight gain was obviously this factor that's causing. And look, we found now that there's a lot of other risk factors, as we'll go into in this podcast. But look, before the 1980s, there was some pretty severe treatment that they would do, but it would be surgical. So we're talking about jaw surgery, even tracheostomies, to try and get around the obstruction part. And the amazing thing about this is the CPAP was actually invented in Australia, here in Sydney. And his name was Dr. Colin Sullivan, who was researching at the time sudden infant death syndrome, SIDS. And they were having young children, the neonates, where they actually had to do positive pressure in airways. And he saw this sleep apnea and said, well, what happens if you could keep the airway open by keeping a steady stream of air? Increase the air pressure. Now, his actual idea sounded a little bit crazy. He said, what if I get a big swimming pool pipe and attach it to a blower? And so which doesn't sound like something you want to stick on your face, but
A vigorous massage.
that's right. And so, but he actually started putting one together. He used household items. He used a flexible plastic tubing. He got handmade nasal tubes and glued and taped them together. He got some straps to hold this little mask in place, and he got a vacuum cleaner motor to provide the continuous pressure. And he ended up trialing this on one of his patients who had severe sleep apnea. And essentially, with using this prototype, they slept soundly and the symptoms resolved. And so this patient had hundreds of apneic episodes overnight. Well, they pretty much resolved.
With this sort of cobbled together machine, which sounds like it's out of Wallace and Gromit.
That's right. Wow. And so he ended up treating 5 patients and essentially it eliminated these episodes.
The machine was an experiment, but the experiment turned into the treatment. It was an amazing result. At the time, though, I never imagined there'd be such a need for continuous positive airway pressure or CPAP machines.
And so we are actually at this point now where we have a very sort of treatable condition. It can significantly affect patients' lives. When they're full on, they may not even knowing they're having symptoms. And so we are getting better at recognizing this, but this is something that we're wanting to sort of alert not just doctors and healthcare professionals, but patients and get the better understanding and then hopefully resolve a lot of these symptoms.
And we'll all sleep better for it. Dr. Saul Gilbert completed a PhD in human circadian physiology in 2003 and has gone on to manage sleep laboratories in private hospitals across metropolitan Adelaide. Saul continues his interest in research and currently holds adjunct research positions at the Adelaide University and Central Queensland University. As Managing Director of the Oasis Adelaide, Saul brings over 25 years of research and clinical experience in sleep psychophysiology. With the increasing awareness of the importance of sleep and its impact on many aspects of our increasingly complex daily lives, Saul believes sleep units are in a unique position to offer expert advice on and access to relevant emerging technological solutions to our increasingly complex, multifactorial sleep and lifestyle problems. Saul's our guest here on This Medical Life podcast. Saul, welcome.
Thanks, Steve.
I'm going to kick things off with a really easy question. How common is sleep apnea?
Well, I mean, yes, it's a very good question. And I think it really depends on the metric that we use. I would say that it could be up to 20% of the population could have sleep apnea. But of course, it really depends on how severe it is. So some people might be in the more mild area. Some people might be in the more severe range. And it comes down to really a couple of factors. So one is how symptomatic that person is. So if somebody is very symptomatic, they're feeling sleepy, finding it difficult to carry out their daily activities, then even if they were at the milder end, that would certainly warrant some kind of intervention, or at least to assess some kind of intervention's efficacy. Because of course, sleep is multifactorial. So someone might have some sleep apnea, but they might have some insomnia. They might have some other issues as well. And so, that's, I think, one of the things that we do try to address at the Oasis as well, is that sleep is not just about one thing or another. It's a spectrum of different things.
It's going to be a hard question, but what is normal sleep?
Indeed. Well, I guess normal sleep really, it depends on, again, what metric that we're using. And when people ask me, I'm always thinking about where they're coming from exactly. So we can certainly characterize it as being changes in consciousness and going through different types of sleep across the night. So broadly speaking, we can break it down into two, basic types. We've got a rapid eye movement sleep, which people probably would know of as dreaming sleep. And that's a very particular type of sleep where we are, contrary to popular opinion, it's not very deep sleep, but our brain is very active and our brain's kind of acting out scenarios. And then we have non-REM sleep, which is amazingly coined.
Yes.
I think a scientist came up with that one. And that one is further broken down into several stages. So from lighter to deeper sleep. And so again, very imaginatively described stage 1, 2, and 3. So stage 1 is like a transitional stage between wakefulness and sleep. And if I was to go into a room when someone was in stage 1 and ask them if they thought that they were asleep, they would typically say that they weren't asleep because they would be able to hear noises and things like that. But we can see very distinct physiological changes in stage 1. Then we've got stage 2, which is the kind of a consolidated light sleep. And we used to think not much happened in that stage of sleep, but now we understand that it is actually quite important, and in particular for the transfer of memory from short-term to long-term memory storage, particularly memories that are kind of like factual based. Okay, and then we've got deep sleep or what we call slow wave sleep, where the brain is very slow and synchronized. All the different neurons are kind of synchronizing. And we know that type of sleep is important for cell repair, hormone regulation, and things like that. And so those are the different types of sleep. But then we have this kind of what we call architecture, which is this sequential changes between each one of those stages across the night. And they usually are like 90-minute cycles that kind of repeat themselves. And that's pretty much what sleep is, yeah. I hope I've answered that succinctly enough.
Indeed. I actually just want to apologise to sleep for how little I have valued it all my life.
Yes, well, that's true. I think hitherto, I mean, and certainly in the Western world, we're kind of encouraged to push through, soldier on, and you'll be right, and almost people would wear it as a badge of honour that they only needed 4 hours, 5 hours of sleep a night. And while it's certainly true that some people don't need more than that, because again, like everything, sleep's a continuum, a bell-shaped curve. So we can say on average, between 7 and 8 hours is needed. But that means that some people can actually get by, not just get by, but they don't need more than 5 or 6 hours. But regrettably, and we do meet some of these people in the sleep lab, some people need like 9, 10 hours. And for those people, it's extremely difficult for them to function, because if they need 9 or so hours of sleep every single night, how are you going to fit that in with your social life and work and other things like that? So they do struggle.
There is something when you're looking at these studies called sleep efficiency. What is that?
So sleep efficiency is just a simple metric. It's really the time in bed. The total sleep time over the time in bed as a percentage. So if you imagine when you go to bed and you turn the lights out, that's when we say the time in bed starts. And so how much of that time that you're in bed are you asleep? So a normal, again, this is like age dependent. So if someone is younger, we would expect a normal sleep efficiency to be around 90% or more. But as we get older, that sleep efficiency in the normal people would decrease, so that by the time we're around about 60, like 80 to 85%. But if it's under 85% or 80%, then that would be, probably indicating that there's some kind of issues with your sleep, that you're spending more time awake than you should during the night.
Actually, that brings in a part of our life which has now changed with televisions and handheld devices.
100%.
Has our sleep efficiency changed in the past decade or so?
It's a good question, and I'm not sure that it's changed. Well, I mean, I see that it's changed, certainly in the people that I speak with, and I think that you only have to understand how really sleep is regulated to understand that it almost certainly must be, because essentially what tells us our body that it's nighttime is a hormone called melatonin, and there's this ingenious, as with so many things in physiology, it's just such a marvel to see the human body in action and all these different systems, interacting together. So there's this ingenious solution that the body has. So there's a hormone called melatonin. It's secreted from the pineal gland in a little area in the brain. And simply put, that hormone is inhibited by light. And there's a direct neural link from the eyes to this area of the brain where it's produced. And well, not produced, but the body clock, the suprachiasmatic nucleus. And so when there's light, that inhibits melatonin, and so that tells the body that it's dark. Okay, so for animals which are nocturnal, like rats, for example, that is a marker of activity, whereas for humans, obviously, it's not. And as you said, Travis, essentially with our light, with screens and light and whatnot, that they can very effectively inhibit melatonin. And so what the effect of that is that pushes our body clock back. So it tells our body clock that it's not yet dark, when in fact it is. And so that has a flow-on effect to making it harder for us to wake up in the morning. And there's actually like two processes that interact together that give us a consolidated bout of sleep. So we have a homeostatic drive and a circadian drive, and they combine together to give us this like 8 hours of sleep. So homeostatic drive just builds up the longer we're awake, and then that drops off pretty quickly as soon as we fall asleep. Then the circadian driver is like a bell-shaped driver, and that maximally drives sleep at around about 4 o'clock in the morning. And so this is what people often experience who have these kind of circadian delays from phone use, is that they wake up around about 2 or 3 o'clock in the morning and they can't get back to sleep. And the reason why is because the homeostatic drive has dropped off, but the circadian drive has been delayed by an hour or so because of the screen use. And so then they wake up, if they go to the toilet or a noise wakes them up, they can't get back to sleep. And then that's when insomnia can start. If they're worried about work or something like that, the brain starts to tick, 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 tick. And then, you're basically stuffed after that.
So we're looking at sleep apnea in this episode, but I noticed that there is different tests for sleep apnea, things like home versus sleep studies, as you mentioned. Can you explain the difference between these testings?
Sure. I mean, so broadly speaking, they're more or less equivalent in certain elements. I would say that we can divide. I suppose, strictly speaking, they're called level 1, which is a laboratory or an attended study, and then we have level 2, which is a home sleep study. So Medicare would say that a home sleep study is specific, and this is in the item number, specifically indicated for the assessment of obstructive sleep apnea. So only obstructive sleep apnea. That's the only thing that it's meant to be looking for in uncomplicated individuals, so people who are otherwise healthy. Okay, so they're meant to be a kind of way to kind of reduce that bottleneck of the level 1s. So they have got, they typically have fewer channels than a level 1, and of course they're not attended, and the sampling rate is often a bit different, and also the way that they're analysed is a bit different. But broadly speaking, that's the reason. So people who analyse them are looking for obstructive sleep apnea, and that's it. Whereas a level 1, is more comprehensive. It includes video monitoring for a start, more channels. It's more customizable. So really, for anything, obviously you can look at sleep apnea, obstructive sleep apnea, but if it's complex sleep apnea, central sleep apnea, limb movement disorders, parasomnias, anything else, and or if someone has got any kind of comorbid conditions, if they've got AF, if they've got some kind of heart issues, respiratory issues, anything else like that, a level 1 is the way to go. And also, of course, if it's for any kind of assessment of efficacy. So maybe someone's on CPAP, it's not working very well. Maybe they've got like an oral appliance that they need to have tested to make sure it's working. All of those things are a level 1, and Medicare only wants that to occur. So it is important that GPs know those two differences, because unfortunately there have been certain more unscrupulous providers who have kind of come into the landscape and marketed very heavily as though they can do all these things. That's wonderful, wonderful, wonderful. But actually Medicare doesn't want that to occur for obvious reasons.
Now we're talking about then definitions of hypnea. So people under breathing. What are some of probably give us a definition of what that means, but then what symptoms or changes does this produce in the patient?
Yeah, well, it's again, I'm so sorry to be so scientific, but it really depends on how you characterize it. So these definitions have been fluid over time, and they've tried to acknowledge differences in technology which is being used and whatnot. So I won't go into the exact definition because it does change from time to time and on different like options you can have. But broadly speaking, it's a reduction in flow. Okay, so that makes sense. So if you imagine the airway is like a tube that basically connects the mouth to the lungs, and what happens when you have sleep apnea is this tube starts to get like flattened down, like from either the tissues, the tongue, or any one of a number of combinations. So the airflow that's reaching the lungs is simply reduced because this airway is narrowing. So the consequence is, it has to last at least 10 seconds. That's across all metrics is the same, and it has to be associated with either an arousal from sleep and or a meaningful level of oxygen desaturation. There are, again, different metrics. 3% and 4% tend to be the standards. 4% is typically considered more used for cardiologists because they have more, I'm sorry, my cat might wander across the screen in a minute. I do apologize. So they have more better associations with cardiovascular issues, but nevertheless, so it's essentially a metric of either sleep fragmentation as a consequence of this airway narrowing and or cardiovascular effects through reduced oxygen. Okay, so if you imagine if you're not getting enough oxygen, then your body is obviously under some kind of stress, and as we know about how the oxygen is recorded, it's not just when our oxygen level drops under 9%, we're only getting about half of the oxygen that our body needs. Okay, so I always talk to patients. I say, if you got 90% on a test, you'd be pretty happy with that, but that's not the same for oxygen. Okay, so a high level can still mean a significant hypoxic debt. And then, of course, the arousals, you're having sleep fragmentation. And as we were talking about before, if you're not getting good quality sleep, you're going to feel tired. Okay, so they're broadly speaking the two issues. So one is sleepiness, the other one is these cardiovascular effects, which can increase the chance of having a heart attack, stroke, and even the things about sleep deprivation. We know that experimentally that if we reduce just deep sleep, so stage 3, in healthy people, we can start to develop insulin resistance in those people. So there's a strong link between that type of sleep and the development of type 2 diabetes. And also there's some very interesting research that's come out recently that's shown that that deep sleep as well is important for the flushing out of these amyloid proteins, these kind of negative oxidative proteins that can cause what they think is causing things like dementia and that kind of thing, Alzheimer's. So it's very interesting.
Now, you mentioned you can actually tell the difference between central and obstructive sleep apnea on sleep studies. How are you able to manage that?
Well, we have the bands around the chest and around the abdomen, and so we can measure respiratory effort. It's very simple. So we have like flow, that we can measure the air coming in and out of the mouth, and then we have effort, some kind of effort metric, so we can actually look at when somebody's trying to breathe. So if someone has obstructive sleep apnea, that's as the name implied, it's an obstruction of the airway. So the patient's still trying to breathe, but their air is being reduced. And so they try and breathe out harder and harder and harder, and then they overcome the obstruction, and that usually leads to an arousal. But in the case of central sleep apnea, it's not an obstruction. It's actually usually to do with the way that things like CO2 is measured. And so it's simply put, the drive for breathing is not there. Okay, so the brain is not telling the body to breathe. And for those conditions, they tend to be more complex because, like with one of the most common forms of therapy, or at least the first line of therapy for sleep apnea is called CPAP. Okay, another imaginative scientific name, so continuous positive airway pressure. And it just really has been splinting the airway open. And the analogy I would use for that is not giving oxygen, it's just like a party whistle. And when you blow into the party whistle, the paper opens up and becomes a rigid tube. That's all that CPAP's doing to the airway. So it's just keeping it open so you can breathe. With people with central sleep apnea, it's not an obstruction, so that's not the problem. And for those people, if we give them CPAP, it can actually make it worse. Because what tends to happen with when you first go on CPAP, you tend to what we call hyperventilate. So you just take deeper breaths, which can tend to blow off a very small amount of CO2. For those people with central sleep apnea, their baseline CO2 level is already a bit low. And so just that little bit of a drop can actually exacerbate it. And so, again, that's why it's really important that you get diagnosed correctly, because if you have the wrong diagnosis, you could be put on the wrong therapy, and then you can actually have a worsening of your symptoms, or just be, misdiagnosed. And so it's terrible. The other thing that could happen is you have like an overlap. You might have mild sleep apnea with another sleep disorder, and if you have the wrong sleep study, you find that you're not feeling any better, and so you don't ever try to have it investigated again. You just think, no, I did a sleep study, it didn't work, I didn't have anything, it's not a problem. But you've just got another sleep disorder that's just been missed. So it is important to have the right sleep study.
So we're looking at then different categories of sleep apnea. Can you take us through what mild, moderate, and severe mean?
Yeah. So again, I've been saying this, the whole thing is about metrics, and there's a continuum, and so they are arbitrary in some form or another. And so differing, research papers will say different things, and different groups talk about different things. But broadly, I'll use the kind of most conventional metric. So it's not that having any kind of sleep apnea at all means that you've got a problem. So we would say anything less than 5 respiratory events per hour on average across the whole night is considered normal, okay? Then if you have between 5 and 15 events per hour, that would be considered mild. And again, if you had mild sleep apnea, you probably wouldn't have any kind of therapeutic intervention unless, of course, as I mentioned before, you were symptomatic. Then you move into the moderate range, which is, between 15 and 30. And so that is where you would start to consider some kind of intervention most typically. And then if it was severe, which is more than 30 per hour, so again, that's like 1 every couple of minutes, which is quite regular. And so that then it would definitely be requiring some kind of intervention. Now, there are a couple of notable caveats to that, and that's about severity in terms of the events themselves. So what's happening with the oxygen? So for example, I might have mentioned this to you before, I might have not, I can't remember now. So in dreaming sleep, we're essentially paralyzed so that we can't act out our dreams. Okay, and because of that, our muscle tone is much lower than even other types of sleep. And as I mentioned before, sleep apnea is this kind of collapse of the airway. So the smooth muscle in the airway itself is more floppy, and then of course the other muscles are more floppy as well. So we tend to have more severe sleep apnea in dreaming sleep. And we also tend to have more severe sleep apnea on our backs because you've got gravity pushing down, and that can push the tongue back more onto the airway. So some people might have mild to moderate sleep apnea on average by that metric I just mentioned before. But when they have them, their oxygen could be dropping down to 80% or less. Right? So in those instances, you would still need therapy. So if your oxygen level is dropping under 85%, then you're really getting very, very much less than the oxygen level which is required, to the extent that your body's having to redistribute blood flow to kind of supply blood to the brain, to the heart. So other organs are definitely getting significantly less oxygen. And also the heart's being put under quite a lot more pressure to pump faster and whatnot. So even though the metric might be low, if your oxygen level is also low, that would also warrant intervention, in particular if it's in REM sleep. If it's just positional, you could advocate for maybe sleeping on their side, and there are devices that you can use that, vibrate when you're on your back to help kind of encourage you to sleep on your side. And so that's what I was, broadly speaking again. So therapy isn't just about one thing or another. And again, the emerging fields that we're talking about combinational therapy, so maybe CPAP with a positional device will be more effective, or like an oral appliance and a positional device for certain people. And we're now moving into other areas as well. And I know that you haven't asked at all, but sleep apnea isn't just about the airway, okay? So sleep apnea is actually about 3 different things. So one is the collapsibility of the airway, the other one is the arousability of the individual, and the third thing is what we call loop gain, which is this instability around arousals with breathing. And so those 3 things interact to cause sleep apnea. And if somebody's particular one of those is more dominant, so for example, if loop gain was the dominant part of their sleep apnea, CPAP can in those people be more challenging because they have to be stably asleep for it to work. And if they're always waking up, they're getting this instability and causing these kind of changes in breathing, which is linking to this central component I was talking about before. So all I'm saying is complex.
There are.
I haven't overly muddied the waters there.
It's the stuff nightmares are made of.
I know, right?
Now, there are a lot of mobile phone apps for sleep available. Are any of them useful?
Yeah, I'm never wanting to poo-poo that kind of thing. I think that engagement is really good to a point. So I think we have to acknowledge that they are good in some capacity, but how much so? We don't want to have our lives ruled by them. I think that probably the best thing they can do is help give us an idea about what's going on. And if it's saying there's something of concern, perhaps you might want to go and see your GP and have a discussion about it and have a proper sleep study, which is really the way to go. But in terms of things like how long you're sleeping for, yeah, it can be pretty good. How much time you're in dreaming sleep, probably not so much, because dreaming sleep, it could be confused with moving, or vice versa. I know that, for example, some apps do record oxygen and that kind of thing, and so those aren't too bad. But again, they are prone to movement and things like that, so they could get a bit of a suboptimal period, which would be inferred as a desaturation, but it may not be. So again, is there something there or not? If it's normal, that's great, carry on. If there's something problematic there, and it seems to be regular, then maybe go and see your GP and have a discussion. But don't obsess over it, and don't think, I've got to do this, I've got to do that. It should help you to work out what's going on in my life, basically.
There's something called the multiple sleep latency test. What's that?
Yeah, well, multiple sleep latency test is a very specialized test that's done during the day, and that's to screen for not sleep apnea or anything like that. So I kind of alluded to before, there are different types of sleep disorders. So there are ones which we call of central hypersomnolence. So things like, in the cultural zeitgeist now, people do hear of this one called narcolepsy, which in its classic form is characterized by loss of neurons in the brain that help regulate wakefulness. So it's actually more of an autoimmune disorder, interestingly enough. And so that is characterized by, people feeling very sleepy, and also, more importantly, that they're as likely to go into dreaming sleep from wakefulness as they are into any other type of sleep. So for a normal person, you feel sleepy, you go to sleep, you go into light sleep, deep sleep, then dreaming sleep. That's the kind of the pattern, certainly during the day. Whereas with people with narcolepsy of that type, they can just fall asleep and just go straight into dreaming sleep, which obviously can be problematic for them. And also just this switching is just very quick. So I can just suddenly switch from wake to sleep. So they can just fall asleep very quickly. So that's something that we look for. And also there's kind of an umbrella diagnosis called idiopathic hypersomnia, which, if you know what idiopathic means, just means that we don't know. So we don't know why you're sleepy, but you're sleepy. And but it's still a diagnosis, and it can be managed. So it's really about diagnosis and also management through the Department of Health with medications that come under the PBS. So you basically have naps across the day, and if you fall asleep quickly across the day, then you would be considered to have a pathological sleep disorder of some description. And then it's up to the physician and also the type of sleep that you go into that will help determine which one it is.
Wow, so most cats have that.
Yeah, well, that's right. I think cats can sleep anywhere. It's a good question about cat sleep. I'm not sure exactly what type of sleep they go into during the day. If they go into dreaming sleep, I think they probably do.
Now, we hear a lot about people who are loud snorers should be, people clearly stopping breathing during their actual sleep. But who is considered, or who should be advised to have sleep studies?
Yeah, I mean, essentially anyone, correct. So I guess we can broadly look at it in a couple of things. So one is sleep apnea. So do you snore? Do you have high blood pressure? Do you have any kind of cardiovascular issues? Are you overweight? And of course, are you feeling sleepy during the day? So anyone with any of those symptoms, definitely they should have a sleep study of some description. Go and see your GP, have a chat, and hopefully they can, recommend the right one for you. These Medicare questions are all part of it now, so that helps. But regardless, if you are having any kind of what we call non-restorative sleep, so if you are feeling that you're just sleeping, but you're not feeling any better after you slept, or you're waking feeling tired, just a lack of energy. All of those things could be a sleep disorder. It just may not be sleep apnea. So you might have a limb disorder, you might have, insomnia or some kind of combination thereof. As I mentioned before, you might have some sleep apnea, some insomnia, something else. So anything where you're finding that your sleep is not where you want it to be and or your energy isn't where it should be. So that doesn't mean that you have a sleep disorder, but you can go and see your GP and have a discussion. And most likely they could refer you on for a sleep study. The only one where we would still want to see you, even though the sleep study might not be the first step, is if it's just for insomnia, because we do have sleep psychologists who do cognitive behavioral therapy for insomnia. So definitely still come to us. That's the beautiful thing about our lab is we do everything, and we can kind of send people where they need to go. So treat sleep as a holistic thing and work out where to go. But you still need to see your GP at least initially, or you can give us a call and ask what you think you should do, and we can advise you.
Just one quick question about CPAP. Wonderful technology. And I remember when I got my glasses, I said to my optometrist, can I wean myself off? He says, no, once you're here, you've got glasses for life. Is CPAP the same sort of technology? Is it something that once you're using it, you'll be doing it forever? Does that mean the system...
No. It's a good question. And again, it depends on the type of sleep apnea that you have. So obviously, if it's obstructive sleep apnea, then there is a chance that you may not need to use it forever. It depends on what's the contributing factor. So if you're very overweight and you were to go on CPAP, that would help you lose weight, because essentially you can, once you become stable on CPAP, you can your oxygen level is more stable, your energy level is better. So you'll be able to have more energy to exercise, lose some weight. And when you exercise as well, you actually burn fat rather than just depleting your glycogen stores, which is what usually happens when people exercise and they have uncontrolled sleep apnea. And so then if you lost the weight, your severity might decrease to the extent that you don't need to go on therapy, which would be a great outcome. But if you were not overweight already and it was more because of some kind of anatomical reason, maybe you had retrognathia or enlarged tonsils or whatever, like a big tongue, so even if you lost weight, you might not have a huge difference. So it's hard to say again, but it's possible.
If someone has to do a sleep study at your premises, for example, and they're so used to sleeping with a partner, close to their partner, and they find it uncomfortable when they're not, is that something that's accommodated, or is that something where, no, it's absolutely impossible, you have to be by yourself?
So it's a good question. So our default position under those circumstances, no, you can't, because, you have to be alone. But of course, if somebody is having some kind of, disability, physical or mental, or they're a child, absolutely they can. And we have parents or carers staying in the room, not in the bed, but we either put them in an adjacent room or we get just a little trundle bed and put it on the floor. We usually don't like to do it under normal circumstances because some people just complain a lot, and obviously, in terms of data integrity, you want to have just, as many things the same as possible. So we typically say no. And if they had a sleep disorder, they should be all right. But yeah, for those clinical or other examples, 100%, and we do all the time.
Just finally, have you got any last words of advice for doctors or healthcare professionals about sleep and sleep studies?
I think, as I said before, it's more complicated than I think some people realize, and we do more than what people realize. So I think, if you had a concern about a patient and their sleep, I think it's always a good idea just to send them on. And, noting, of course, there are Medicare questionnaires that can be completed that will assist. GPs happy to have a chat about any questions that they might have.
Dr. Saul Gilbert, thank you very much for being part of This Medical Life.
Thanks, Steve. Thanks, Travis.
Dr. Anna Kruevit is a respiratory and sleep medicine and general medicine physician. He's a member of several national and international respiratory, sleep and internal medicine societies, and also involved in research. His interests include chronic cough, airways disease, pleural disease, lung cancer, interventional pulmonology, obstructive sleep apnea, complex respiratory sleep disorders, obesity, and Indigenous health. Anuk is our guest on This Medical Life podcast to discuss sleep apnea. Welcome to our podcast.
Thank you very much. Thank you for the invitation. Very pleased to be here.
Excellent. We've got a lot to get into. I think it affects a good portion of our population too. First off, though, how good are doctors at recognizing someone with sleep apnea?
Yeah, so this condition, I guess it used to be quite under-recognized, quite overlooked if you go back 10, 15, 20 years ago. And really, that was all because of the lack of resources in testing, treatment, and options of treatment, and also the costs associated with the investigation and management of these patients. However, it is the most common sleep-related breathing disorder. So it's really, really important that now it is gaining a lot more recognition in the medical field. Now, if you go back to one of the latest population study or prevalence studies for obstructive sleep apnea, and there was a global estimation in 2019 published in the Lancet Respiratory Journal. It was a systemic review of all the data from over 16 countries in the world, including adults aged 30 to 69 years. And they collected all the data and found that if a patient with at least moderate up to severe obstructive sleep apnea, that accounted for about almost 1 billion people in the world, 936 million. And if you look at just the patients with moderate to severe obstructive sleep apnea, that number was around 425 million people. Now, these studies included estimates from China, Brazil, India, America, Australia included. The prevalence, interestingly, was found to be highest in China. So overall, though, if you're talking an overall estimate, it would be around 15 to 20%, but it could go up to well over 50% countries. In Australia, now, if I can take us back on a bit of a journey in time, I think our real or the biggest population study was back in 1995. It was a small rural town in Western Australia called Busselton. And we've been studying the population within this rural town longitudinally up until now even. Back then, they had a population of around 12,000 people, and they recruited 311 subjects, just males, aged 40 to 65. And they found the prevalence back then to be just 4.7%, sorry. But then they released more data in 2007, and then the latest in 2021, and the figures have been about 20 to 24% in males and about 10% in females, and this included about 3,600 patients at the latest. So it's actually a very common condition, certainly the most common sleep-related breathing disorder.
Do you think it's getting worse, or are we just getting better at diagnosing it?
It's both, yes. So with the commercialization of testing these days as well, privately, we have a lot more access to the investigations. And also, as we will talk a bit later, obstructive sleep apnea is closely linked to our weight. So now that there's a bit of an obesity epidemic, so the prevalence is rising together with it.
Are there any useful questions or guidelines, screening tests, questionnaires for patients to help identify people who are at risk or who have sleep apnea?
Yes, absolutely. So we've got 3 good tools or questionnaires that we use routinely, and one of which is really validated by our very own Adelaide group of sleep physicians. So there are 3 of them: the Berlin questionnaire, which came first, and the OSA 50, and the Stop Bang questionnaire. And these questionnaires have been designed and validated to see who is at the higher risk of having at least moderate to severe obstructive sleep apnea. And that facilitates our patient selection in terms of testing. Particularly the OSA 50 and the Berlin questionnaires were developed and validated for use in primary care settings. And the OSA 50 is pretty much the favorite tool at the moment due to its shorter, or its brevity, and simple scoring system. And as I mentioned, it's validated by our Australian group or Adelaide group of sleep physicians. They've got very high specificity. The OSA 50 has got, sensitivity. The OSA 50 has a high 94% sensitivity in detection of these moderate to severe sleep apnea patients. The Stop Bang score is about 90%, whereas the Berlin questionnaire has about 82% sensitivity. And the OSA 50 system works by measuring 4 items. So the O is for obesity or the waist circumference. Male more than 102 centimeters, whereas female more than 88 centimeters. That's a score of 3. Significance S for the significant snoring, another score of 3. A is for apnea, witness apneas by bed partners or family members, a score of 2, and 50 is obviously for the age of over 50, another score of 2. So it's a total score of 10. A score of 5 out of 10 is significant for the high risk. As a Stop Bang score is a questionnaire with 8 items, and obviously asking for the similar questions: snoring, tiredness, obscenity, throwing in blood pressure, hypertension as another factor, and a score of 3 out of 8 would constitute high risk. Berlin questionnaire is a little bit more tedious to use. It's an 11-item tool. They separate them into 3 categories, and you've got to answer at least 2 for yes in each category, to score. But if you've got positive 2 out of 3 positive categories, then you constitute high risk.
Now, you've mentioned snoring a few times. Is snoring normal, or does a loud snore mean anything? Can you have sleep apnea without snoring?
Yeah, so I guess we probably should start by describing what is obstructive sleep apnea. Obstructive sleep apnea is upper airway obstruction during sleep, resulting in repetitive collapse, complete or partial collapse of the upper airways, and therefore partial breathing pauses. So the snoring is just the beginning of the obstruction. However, what is really important is that when these breathing pauses happen, they lead to oxygen desaturations, arousals from deep sleep. And these are really the physiological effects of obstructive sleep apnea that we worry about. So essentially what it means is that if you have loud snoring, but you don't have the physiological problems, then you really just have primary snoring and not obstructive sleep apnea. But on the other hand, you can have soft snoring, but suffer from those physiological effects and still have obstructive sleep apnea. So some patients might be surprised, certain men in particular, me included, that you can be surprised you've got significant obstructive sleep apnea without such bad snoring. Yeah.
Now, you've mentioned weight. Is there any other common risk factors for sleep apnea?
Yes, so there are well-established risk factors. The number one is weight. We've found in many studies around the world that weight has a pretty much direct relationship with the severity of obstructive sleep apnea. And some studies, it can be as bad as, weight going up by 10%, and the risk of obstructive sleep apnea goes up by 6-fold.
Wow.
Reciprocally, if you lose weight, then everything gets better as well. Yeah. Another risk factor, of course, is age. As in the questionnaire, age above the age of 50 becomes a risk factor. And for all three of us men, we are more prone than women. We've got a 2 to 3 higher risk, 2 to 3-fold higher risk of developing obstructive sleep apnea. Another risk factor is anatomy, craniofacial features, retinatism, micronatism, small jawline, a short mandible size, and obviously tonsillar adenoid hypertrophy, anything that crowds the oropharynx. Some other less well-established risk factors could be family history of obstructive sleep apnea, and that could be genetic or environmental issues, chronic nasal congestion, excess alcohol intake, sedatives, medication, and other anatomy factors, thyroid goiter, some certain neuromuscular diseases.
What are the symptoms of sleep apnea?
Obviously, snoring is number one. Yeah. Yes, and as I mentioned, it could be soft snoring, it could be loud snoring, and pauses in your breathing. So a family member, bed partners, they go on holidays. If instead of just peaceful snoring, you start to see pauses in the breathing. And obviously, A2 is disrupted sleep. Patients often start waking up at night, and if you ask them, what is the reason for waking up? Just I'm not sure, just opening my eyes, frequently throughout the night. Some people do wake up with what we call choking or gasping arousals from their breathing pauses. Right? They can often run into frequent nocturia problem as well. And then during the daytime, because of the frequent awakenings and therefore lack of deep sleep, then they run into unrefreshing sleep, excessive sleepiness, fatigue, poor concentration, poor memory, mood disturbances, lower libido, and so forth. Things that are representative of hormonal dysfunctions. Yeah.
Some of these, of course, people might present with without having sleep apnea. Are we looking for a combination of them for it to fall into that category?
Some of these symptoms?
Yes.
Yes, absolutely. They could present with very minor symptoms, or they could present with a combination of significant symptoms. Yes, you can have a lot of patients who come in because they have been asked to have the sleep study without significant symptoms, and they surprise themselves, after the test results come back, indicating severe disease, for example. Yes. So you could have a very good sleep and have a terrible obstructive sleep apnea. Yes.
I think love means referring your partner to a sleep study.
Yeah. That's right.
Now we're talking about hypoxic events and hypnea. Do these have, if someone has an event for 5 years, are they always reversible, or can they have lasting physiological effects?
I guess our body and the brain are an amazing organ. Now, really, it very much depends on how severe and our status as a patient and our comorbidities and our risk factors. So if you talk about obstructive sleep apnea, I'd like us to look at the disease as a disease on a spectrum of severity. Right? On one end, you've got just the primary snoring, patients who don't have the physiological problem of obstructive sleep apnea. And then as we have more comorbidities, more risk factors, as we age, as we gain weight, the disease becomes more severe. So our body compensates and corrects for those physiological abnormalities to a point before everything falls apart. So with each hypopnea episode and low oxygen level, the sympathetic nervous system gets activated into overdrive, the cortisol hormones released, the heart doesn't get to rest, basically. So that's why, we start to see resistant hypertension. For example, you start to see high sugar, diabetes, arrhythmia, atrial fibrillation, cardiovascular diseases, or these associated with obstructive sleep apnea. So when the body fails to correct the hypoxemia completely each night, we then lay the problems like pulmonary hypertension as a later complication. So if you've got these hypoxic events and then the body starts to fail to compensate for each night, and you've got this chronically low oxygen level, and then then you enter into the other end of the spectrum of severity.
Are there any medications, let's exclude alcohol for the moment, that contribute to or exacerbate sleep apnea?
The South Australia famous for our wines.
Yes.
So yes, there are medications, particularly medications that blunt our arousal from sleep or relax our muscles. So particularly sedatives like benzodiazepines, the Valium, the temazepam, and so forth. There are certain antipsychotics or antidepressants with sedative properties as well. Yes, they do contribute to obstructive sleep apnea. And as you mentioned, the alcohol. So it's important to assess the risk factors before prescribing these medications, particularly if patients come in with just insomnia. Because insomnia can be a symptom of obstructive sleep apnea. The frequent awakenings, I don't know why I can't go back to sleep.
So looking at treatment options, so sleep study is the diagnostic real measure of this. But when we're talking treatments, can you tell us about what the treatments are and how effective they are?
Yeah, absolutely. So when we talk about obstructive sleep apnea treatment, you always want to focus more on non-pharmacological or non-active interventions first. So all these lifestyle interventions, the weight reduction, supine sleep minimization, the alcohol, the sedative avoidance. So as mentioned, with the weight, how it's closely linked to the severity of the disease. So for example, if you drop your body mass index by 20%, you could be looking at in some studies of an improvement of over 50% in your obstructive sleep apnea severity. But I also emphasize it's a lifelong commitment. Weight loss is a drug, so you need to lose the weight and keep the weight off for the condition to stay away. Otherwise, everything goes back to being severe again. But weight loss is important for many other diseases, not just obstructive sleep apnea. So it has many benefits. Supine sleep minimization, usually more effective as a sole therapy in patients with less severe obstructive sleep apnea, patients who may be less obese or overweight, and often in younger patients. And then you come to active intervention choices, and we've got continuous positive airway pressure or CPAP therapy, very famous. What it does, it continuously splints the airways open, preventing it from collapsing. I guess it's the most effective if the patient can use it and adhere to the therapy, especially in moderate to severe disease patients. The second choice would be mandibular advancement device or splint. It works by keeping your mandible forward and keeping the tongue and the muscles, the back of your throat, pulled forward in your sleep. You've got also airway surgery for patients with surgically correctable airway obstruction. There are many forms of surgery, including adenoid surgery, tonsillectomy surgeries, to tongue surgeries, to palatal surgery called uvulopalatopharyngoplasty surgery, or even mandibular surgery, maxillomandibular advancement surgery for people with retonatism, micronatism. And then the latest, which is getting a lot of attention, but it's not widely available, is hypoglossal nerve stimulation. So you can have, much like a heart pacemaker, now you've got a tongue pacemaker, right? An implantable device with electrical stimulation of your hypoglossal nerve and keeping the tongue, the muscle tone of the tongue high at night, in your sleep. I guess the criteria is very strict at the moment. Obviously, it's better to consider in patients with at least moderate sleep apnea, patients who are not too overweight or obese, BMI preferably less than 32 kilogram per meter squared, and it's done by ear, nose, and throat surgeons. And there's a big trial going on in Australia as well. But the treatment really started in America, if I'm correct. Yes.
What does that feel like if you have that implanted?
Would you like to try?
I'm not in a hurry. Is it like an electric fence, and your tongue goes somewhere, and then it beeps or buzzes or whatever?
Yes.
I don't understand.
So it doesn't directly stimulate your tongue muscle; it stimulates the nerve. So you can sleep through it without realizing anything's happening, but the tongue stiffens up when it starts to relax too far. The diaphragm is activated to try to get you to take that breath. When you start to pause, and yes, and the obstruction. Yeah.
Looking at the different kinds of modalities there, particularly we'll focus on just the oral appliance and CPAP. What is the difference between who gets the oral appliance and who gets CPAP?
The CPAP is the most effective, particularly in severe patients, in normalizing oxygen desaturations level and preventing most obstructive respiratory events. So in mild to moderate patients, then mandible advancement splint can be equally as effective as a CPAP therapy. However, the main point for treatment really is to improve patient compliance, because a drug or any intervention is as good as the compliance rate. It has been well demonstrated that even in severe patients, that the mandible advancement splint, the oral devices, could be the preferred options for many patients rather than the CPAP therapy. And it really depends on many factors in terms of how effective the oral device could be, could be anatomy factors and so forth. And partial treatment is good enough if the patient uses it every day, rather than I use my CPAP maybe 50% of the time, although those good nights are really good, I still don't like to wear them every night, And if you wear the splint every night, then that's a lot better. Yeah. So there are contraindications, so if you use an oral device, such as patients who might need rapid therapy initiation, patients who's highly symptomatic, or they work in very important jobs with commercial license and so forth. Patients who may have severe or prolonged oxygen desaturations, very bad physiological problems, CPAP therapy is preferred. Certain dental conditions, temporomandibular joint disease, insufficient dentition, you may not be suitable for the oral device. And patients who may have trouble with their manual dexterity to adjust the device and so forth. Some of the predictors of benefits of oral device could be patients with younger age, less than 60 years, patients with lower BMI, less than 30, patients with sleep apnea predominantly in supine position, sleeping on their back. Females do better. People with smaller neck circumference, and obviously people with retracted maxilla or mandible. Because that's how the oral devices work.
CPAP is probably the most well-known of all of these, in at least in public discourse. Is there any downside to someone, once they're using a CPAP machine, to continue using it for the rest of their lives? Does it have downsides to that?
No, when it's appropriately adjusted, I don't see really any long-term consequences from using CPAP therapy. However, there are CPAP therapy is dealing with pressure to your airways. Sometimes you can give too much pressure that can lead to some barotrauma, some certain damage to the airways. Now, there are lots of patients that may complain of, I get ear pain every morning. I wake up, I get a lot of ingestion, bloating, and affects the chest tightness waking up in the morning. That is probably more significant in patients with chronic lung disease. That's something to think about. Yeah.
Finally, do you have any final advice for doctors or healthcare professionals about sleep apnea in general?
Yes, absolutely. So I guess I'm a lot happier nowadays, as a sleep physician, that this condition is much better recognized. There's a significant amount of a big increase in testing and early interventions nowadays, but the important message is really regarding management. So we know that in the first 1 to 2 months of therapy, it is the most crucial period of time to really aggressively treat the patients and ensure good compliance rate, and as it predicts a long-term treatment adherence. Right. So when you see a patient struggling with CPAP therapy, for example, in the first couple of months, it's very important to follow them up closely, get them to see the sleep physician early to discuss treatment or alternatives if they're really not liking the therapy. Unfortunately, with the commercialization of CPAP therapy, I have to say that the alternative therapies are not talked about often enough, are not offered to the patient at all, even if they're struggling with the therapy. So that's why, and then the patients tend to give up. Oh, this is a hoax. CPAP therapy is not really, they're trying to sell me products. It's not really the effective therapy I'm looking for, and they don't really know about the alternative therapies. Some patients, you get to see them once that while they've been struggling with CPAP therapy, you fix a certain problem and all is rosy again.
On that note, Dr. Anik Kruvit, thank you very much for being part of This Medical Life.
Oh, my pleasure. You're welcome. Thank you for the invitation again.
This Medical Life is recorded in the Talked About Marketing Studios in Adelaide. For show notes and more information about the podcast, visit thismedicallife.com.au. You can contact the hosts on social media. Dr. Travis Brown can be found on X. His username is @Dr. Travis Brown. That's Dr. Travis Brown. And Steve Davis can be found on LinkedIn. Go to linkedin.com/in/TheRealSteveDavis. This has been a PathNotes Proprietary Limited production.